Good morning, everyone, and welcome to this session on antimicrobial stewardship challenges in the peri-operative setting. My name is Chen. I'm an AMS pharmacist at NCAS at the Doherty, and it was meant to be my colleague Rod James who was meant to be chairing this morning, but unfortunately he's not available. So we've got a great lineup of 4 presentations this morning. And so before I start, I would just like to do an acknowledgement of country. I acknowledge that I'm hosting on the lands of the Wurundjeri people, but would also like to acknowledge the traditional custodians of the various lands on which you are all working and joining us today. And of course, any Aboriginal and Torres Strait Islander people participating in this webinar. And we pay our respects to their elders past and present. Before we get properly underway, just a couple of housekeeping things. So this is a webinar, which means that for all the attendees, we can't see you and we can't hear you. So if you've got any specific questions, if you just type them into the Q&A section at the bottom of your Zoom screen, and we'll endeavour to have a bit of time at the end of each of the presentations to answer any questions, or we can have a quick discussion towards the end if there are any additional questions that arise as well. So our very first presenter for today is Dr. Trisha Peel. She is an infectious diseases and AMS physician. She was awarded her doctorate of philosophy and completed her postdoctoral fellowship at the Mayo Clinic in the US. And her research is focused on improving patient outcomes, including the prevention of infections following surgery. Trish conducts large-scale clinical trials and implementation science research, investigating strategies to prevent surgical site infections. So Trish this morning will be, her presentation will be on bridging the evidence gap, clinical trials for AMS in surgery. So Trish, whenever you're ready, if you'd like to share your screen.
Yep, there you go. Thank you very much for that introduction, Carolyn, and also for the opportunity to present here today. So I'm going to be talking on how we use some clinical trials to try to help bring our surgeons along in improving antimicrobial use in surgery. So I thought it'd be good just to paint a picture as to why this is an important area, although I'm sure many of you are well familiar with this area. But if we look at global data, in high-income countries, 1 procedure is performed per 10 people each year, and this is similar to the data in Australia. We actually know in low and middle-income countries that the demand for surgery actually outstrips the availability. So the number of people who need a surgical procedure in the world is actually far higher. We also know that those patients who are actually able to access and undergo surgery have improvement of quality of life. For example, our patients who undergo joint replacement surgery have pain relief following the procedure, and patients who need heart surgery have improved mortality associated with the surgery. Flowing on from that, we know it also is associated with economic benefits for our patients and also for society as well. And in fact, if you look at it, the benefits of surgery actually are on par with global vaccination programs and also medical treatment of heart disease. So certainly significant benefits associated with surgery. Surgical site infection remains one of the most devastating consequences of infections, of surgery, and probably one of the most feared consequences. And it's associated with suffering for our patients. They frequently need to be readmitted to hospital, have repeat surgery. They often need to have prolonged courses of antibiotics, and it does carry with it a mortality risk as well. We know also that these infections are costly, and data from 2013 suggested that infections cost the US around about $20,000 per year per infection. So again, quite substantial healthcare costs. Importantly, we know also that over half of all these infections are preventable with evidence-based strategies. So what are these strategies? Well, in 2016, the WHO released updated global guidelines for the prevention of surgical site infection. And it's important to note when we talk about surgical site infection prevention, it's not one thing that we do, it's a bundled approach. There's a number of key strategies that help to prevent surgical site infection. And for the focus of today, I'm going to be talking about antibiotics as one of these infection prevention strategies. So we know we give antibiotics as part of surgical antimicrobial prophylaxis. That is, we administer antibiotics prior to surgery to prevent patients getting a surgical site infection or a wound infection. And there's two key areas that the WHO have provided recommendations on regarding surgical antimicrobial prophylaxis. The first is before surgery, only use antibiotics when recommended. So that's to say that not all procedures require antimicrobial prophylaxis, and that the antimicrobials chosen should be covering the common organisms isolated, not every single organism potentially that you can isolate. The other thing is also the WHO have recommended not to continue antibiotics after the wound is closed. That is, once the procedure is finished, the WHO recommend that all antimicrobials cease at that time. And they felt this was because antibiotics were not necessary post-operatively and that they contributed to the spread of antibiotic resistance. We also know that antimicrobial prophylaxis is one of the leading reasons, and in fact is the most common reason a patient will be given antibiotics on any given day in Australia. Unfortunately, it also has a dubious honour of being the leading reason for inappropriate use in the hospital system, with data suggesting up to 2/3 of antimicrobial prescriptions may be non-compliant with guidelines. So the question is, why are our surgeons not following these guidelines? And our work, including work by Courtney as part of her PhD, but also some additional work we've been doing, has been trying to engage with our colleagues as to why they're not following these guidelines or why they're not taking up these recommendations. And there's also another number of other groups who've been doing similar work, including Alex and Jennifer Broom, who've published a lot, and Asmita Charani, who's also published in this area. But the key themes we found is, firstly, the surgeons feel that their outcomes for their patient cohort are, they feel they have the best possible outcomes for their patients, applying the current practices that they're applying, and therefore they're very reluctant to change that practice. Tied to this is they have a strong ownership of risk. That is, that they feel responsible when their patients get a surgical site infection, and they're very unwilling to change practice if they're concerned that it's going to lead to increased risk of infection. They are also highlight that there is a lack of data regarding some of these practices and these recommendations. So again, taking a step back and actually looking at the evidence, when we look at the WHO guidelines that were published, when you actually look at the quality of evidence, and this is what the WHO reported and assessed the evidence as, based on their recommendations, none of the recommendations were based on high quality evidence. In fact, the majority of evidence in the WHO recommendations were based on very low to low quality evidence. We also know that many of these recommendations were drawn from publications that were from the 1970s, 80s and 90s. And we know that surgery has undergone a vast evolution since this time. So we know that the breadth and scope of procedures has increased during this time. The use of technology such as robotic surgery has also increased, and patients are becoming increasingly more complex. For example, we're seeing increased rates of obesity. We're seeing patients who are older patients and patients with other comorbidities that increase their risk of infection. Marching hand in hand with the increased complexity of patients, we also know that we're encountering increasingly more complex bacteria causing surgical site infection. In particular, we're seeing increasing antimicrobial resistance in this cohort. So this is a really important opportunity where we can bridge these evidence gaps through the use of clinical trials and really bring our surgical colleagues along with us when we try to improve antimicrobial use in the surgical setting. So I wanted just to use this as an opportunity to highlight two key evidence gaps and how we're using clinical trials to try to address this. So the first evidence gap was the recommendation by the WHO to only use antibiotics when recommended. Again, the recommendations are that antibiotics don't need to be given for every patient undergoing surgery, only those who have a high risk of infection, for example, colorectal surgery, or when the consequences of infection are severe, such as joint replacement surgery. They also recommend only use an agent that is as narrow as possible to cover the majority of organisms, so don't give broad spectrum where possible. But when you look at the evidence in joint replacement surgery, the guidelines recommending cefazolin for joint replacement surgery are really based on data from 1981, which is a randomized controlled trial showing a benefit compared to placebo with the administration of cefazolin. Since that time, however, since 1981, we know that the types of organisms that we're seeing has changed. From the publication in 1981, methicillin-susceptible Staph aureus was the predominant organism. We now know in Australia that methicillin-resistant Staph aureus, but also methicillin-resistant coag-negative staphs and enterococcus are increasing in frequency and can occur in up to 50% of infections that we see. And data from my PhD, which was a while ago, showed that in Australia, we were potentially not covering about half of the infections if we were just using cefazolin alone. So this raises the question, should we be using broader spectrum antibiotics? That is, should we be adding in a glycopeptide like vancomycin to try and prevent these infections? And there's been a number of cohort studies from around the world that's looked into this with variable results, but this is one publication from the Spanish group that actually showed there was a reduction in the risk of surgical site infection in joint replacement surgery when vancomycin, or in this case, teicoplanin, was added to standard prophylaxis. However, there's always a balance, and this is that, there's potential harms when broadening antimicrobial prophylaxis. And there's been, again, a number of cohort studies showing that the addition of vancomycin to cefazolin is associated with an increased risk of acute kidney injury. We know from data, again, from publications from Courtney and the NCAS group, that vancomycin is not commonly used in orthopaedic surgery. Approximately 5% are receiving vancomycin. However, we do know that a number of centres from around Australia have actually changed over to using dual prophylaxis because of their concerns about the risk of methicillin-resistant organisms. And importantly, we know when assessing the prescriptions for vancomycin use in orthopaedic surgery, nearly 3/4 were actually considered inappropriate. So this is a really important juncture to try to address these evidence gaps, to weigh the benefits and harms before vancomycin use gets firmly embedded in practice. And this is really the germination of the ASAP trial, which is a multi-centre randomised double-blind placebo-controlled trial looking at combination vancomycin and cefazolin in joint replacement surgery. With these trials, you can't do them alone, and we need collaborators such as the Australian Orthopaedic Association and also the Infectious Diseases Society. So it's a fairly simple trial. It was a placebo-controlled trial where half patients were randomised to cefazolin and placebo and half to cefazolin and vanc. We also looked at the unintended harms, including acute kidney injury and the emergence of VRE. And importantly, with this study, we took swabs of the nose and groin of all our patients undergoing surgery to look to see if they were carrying a methicillin-resistant staphylococcus on the day of surgery. And part of the reason for this was to see whether we should be giving vancomycin to all if there was a benefit, or only to those who were covering a multi-resistant or a methicillin-resistant staph. So the trial recruited from 11 sites across Australia, including rural and regional centres and public and private. We've created a large biobank with over 8,000 patient specimens, which we're only just beginning to explore the potential for. I'd love to be able to present the results. We've finished the trial. It's currently blinded, but should be unblinded and reported imminently. So the second evidence gap I wanted to look at and present how we're approaching it is regarding the second recommendation by the WHO, and that is to not continue antibiotics following the completion of surgery. Again, because the WHO deemed that it was unnecessary and contributes to the spread of antimicrobial resistance. So is there data to support it? Well, yes, there is data to support that a single dose is as safe or as effective as multiple doses of antibiotic prophylaxis. This is an older publication, but again, from a number of familiar authors, which looked across the board at different types of surgery and didn't show a benefit with giving multiple doses, so post-operative doses of antimicrobial prophylaxis. And again, some data showing potential impacts of using post-operative doses. So in this study, which is one published by Branch Ellerman, looking at over 79,000 patients undergoing surgery in the US, they looked to see if giving greater than 24 hours of prophylaxis was associated with any benefit. And across a range of surgeries, it wasn't associated with any reduction in the risk of surgical site infection. But importantly, it was associated with an increased risk of acute kidney injury and Clostridioides difficile infection when patients received 48 or greater than 72 hours of antimicrobial prophylaxis. But what about in heart surgery? So we know this is a unique cohort of patients. They require a cardiopulmonary bypass, which is associated with universal endotoxemia. They frequently require ICU admission with mechanical ventilation. They have a lot of lines in situ, and so they are potentially a group where there might be a biologically plausible reason for giving prophylaxis in the post-operative period. And again, when you look at the data, it actually does support giving post-operative doses of prophylaxis. There are 3 studies which were published between 1972 to 2008. All were small, they were of lower quality, and in fact, they used a range of different antibiotics and also a range of durations from 24 out to 5 days of prophylaxis. But when you pulled it together, there was actually a reduction in the odds of infection when you gave post-operative doses of prophylaxis. And again, looking at the NAUSP data, we know that the majority of patients are actually receiving post-operative doses of prophylaxis. Only 22% of patients are receiving intraoperative only. The majority receive up to 24 hours, and then about a third receive 24 to 48 hours. So again, looking at the Branch Ellerman publication in cardiac surgery, extending prophylaxis after 24 hours post-op was not associated with a reduction in the risk of surgical site infection, but again was associated with an increased risk of harm, of acute kidney injury, and also C. difficile infection. So again, another opportunity to try to address the evidence gaps. So this is the Calypso trial, which is a multi-centre adaptive double-blind 3-arm placebo-controlled non-inferiority trial looking at antimicrobial prophylaxis duration. Again, with these trials, we need to have stakeholder buy-in, so we've got support from all the relevant stakeholder groups. So it's a fairly straightforward trial. All patients are getting standard prophylaxis, and then they're randomised to intraoperative only, 24 or 48 hours as a placebo-controlled trial. It's a non-inferiority trial, which means we're looking to see if giving intraoperative doses is as safe as giving post-operative doses of prophylaxis. And also a unique element of this trial is that it's adaptive. And this was really based on feedback from our surgeons who had a degree of reluctance with randomising patients to intraoperative only. And so this trial allows us to potentially remove or drop a trial arm if it's harmful. So, for example, we have interim analysis involved in this trial, and if we find that intraoperative only is associated with an increased risk of surgical site infection, we will drop that arm and continue randomising to 24 and 48 hours. As part of this trial, we're also building up our biobank, so we're collecting rectal samples from our patients to see if the different durations of prophylaxis are associated with alterations in the microbiome, and also looking at how that links to the human inflammatory response. So these trials, obviously, given the low rate of surgical site infections, you need a large cohort of patients. So we're recruiting 9,000 participants from across 25 centres, and it includes both centres in Australia, probably many of the sites that our audience are at the moment, and we're due to begin recruitment in January next year, 2023, and the trial will run for 5 years. So I'll finish there with just some very key messages. The first is that surgery is a common procedure. performed in Australia, but also worldwide. We know that post-operative infections have devastating consequences for our patients. And importantly, over half of these infections are preventable. Despite this, there is a lack of high-quality contemporaneous evidence informing our infection prevention approaches. And that means that our surgeons and anaesthetists are often reluctant to take up these recommendations because of these key evidence gaps. So this presents a really wonderful opportunity for large coordinated clinical trials to address these gaps and to bring our surgical and anaesthetics clinician stakeholders along with us and to try to improve practice or to improve the evidence informing our practice. And again, one of the important things I've learned is how it's important to bring your collaborators and your stakeholders on early, work with them, take into account their concerns, and try to really maximise the impact of your trials. So I'll stop there. Obviously, there's a lot of people who are involved in this work, but I'm happy to answer any questions either now or at the end.
Thank you very much for that, Trish. That was really, really interesting presentation on two phenomenal sounding trials that you've got underway, and we'll be very, very interested to hear the outcome of the ASAP trial soon. So if anybody has any questions, we've got a few minutes if you wanted to type them into the Q&A. Otherwise, I believe, Courtney, you had a couple of questions.
Thanks, Caroline. Yeah, whilst everyone else puts their questions into the Q&A, Trisha, I had a question about the Calypso trial being adaptive. So you said that you had engaged with surgeons and they had flagged that they were concerned about only getting that 24 hours only dose. Could you just elaborate a little bit more on how you went about that? Was that through the professional bodies, or did you do extra scoping, or
Yeah, so we've got some great collaborators here, and we're also collaborating with the Australian and New Zealand Society of Cardiac and Thoracic Surgeons. So that's the representative group across Australia and New Zealand. So that involves 58 sites in Australia and New Zealand who undertake cardiac procedures. So we've engaged with them. So part of it has been survey work, talking to the surgeons, but also interviews and face-to-face meetings with surgeons to discuss things. Part of the problem is, they feel a particular reluctance to giving intraoperative only. And most are very married to their practice, either 24 or 48 hours. They were very worried that if they randomised their patients to intraoperative only, in a traditional trial construct, you would keep randomising them through to the end of the trial. So you'd get to 9,000 patients and then stop and look back. But they were really concerned about if that intraoperative only showed that there was a potential risk of infection, that their patients would be exposed to an unnecessary harm. So this allows us the opportunity to have repeated looks at the data and to potentially drop a harmful arm. And that was really how we got buy-in from the surgeons, that then they were willing to randomise their patients because of that additional safety mechanism built in. Likewise, we're looking at harms, so C. difficile and acute kidney injury. So again, if we find that the 48-hour arm, for example, is associated with an increased risk of harms, we do have that opportunity to drop that arm. And that's all been done by an independent group of experts as part of our DSMC, Data and Safety Monitoring Committee. So again, I think it's important to take into account the concerns of the stakeholders, because otherwise they won't allow you to randomise their patients.
Yeah, absolutely.
Thanks, Trish. I can't wait for you to prove them all wrong.
I mean, with these sort of trials, they all go in with their very preconceived ideas, and I think they always think that one of the things I'm wanting to do as part of this trial is just to ask the surgeon which arm they think their patients got randomised to before and after they get an infection. I think most will think they've got randomised to the arm they like, And then if a patient develops an infection, I'm pretty sure they'll decide that they've been randomized to the intraoperative only. So again,
yeah.
those preconceived ideas.
We do just have a couple of questions in the Q&A. So one of them is, are you going to be starting a trial with the plastic surgeons?
Yeah, I mean, one of my ultimate goals and what we're really working towards is a big platform trial in this area. I have, I don't know, it feels sometimes like I'm an agony aunt, particularly about AMS people dealing with plastic surgeons. They seem to be the real challenging group. So giving prophylaxis in patients undergoing graft surgery and even giving it out to 5 days. It's a very entrenched behaviour. We've tried to address it by talking to our groups and trying to minimise the prophylaxis that they're giving, but they're really staunchly opposed to changing practice without evidence. And actually, again, when you look at it, there's not that much data to support only giving single dose of prophylaxis in those complex head and neck flap surgery. And in fact, for most others, there's not that much evidence as well. So there is some truth when they say there's not evidence to support it, but there is certainly evidence to support that it harms patients. So there's an increased risk of MRSA infection, acute kidney injury, allergic reactions and things. But again, trying to convince them is tricky. So yeah, that's certainly one of the goals, is to really try to use these trials to bring them along and either prove them wrong or prove them right.
Fantastic. And we've probably just got time just for one more question in the Q&A. Will there be any plans to include looking at intraosseous administration of antibiotics for joint surgery?
Yeah, that's the next one of the other questions. So for those who don't know, there's a couple of publications that came out, particularly from the New Zealand group, led by Simon Young, which looked at intraosseous. So that's where they stick a needle into the tibia in patients undergoing knee replacement surgery, and they administer vancomycin through that. They've done some small studies, so randomizing 10 patients to each arm, vancomycin or not, and then measured vancomycin levels and showed that they had higher levels of vancomycin in the joint when intraosseous vancomycin was administered compared to when intraosseous wasn't, but hasn't shown that that's reduced infection. But I know it's caught the imaginations of our surgical cohorts, surgeons. So again, that might be something where you can really incorporate it into a platform trial. Yeah.
Fantastic. Thank you very much for that, Trish. So our next presenter for this morning is Erin Connor. Erin is a pharmacist who's been with the NAUSP team in Adelaide for 8 years. She's been part of the development and rolling out of the NAUSP portal and its subsequent upgrades and data expansions over the years. Working in this space has sparked Erin's interest in public health and expanded roles for pharmacists, and she's now working through obtaining a Master's of Public Health, which is fantastic. Erin's going to be presenting this morning on stratifying theatre data in NAUSP, opportunities and challenges. Take it away, Erin.
Thank you. Yes, I feel like I'm probably the least qualified to be here with everyone else, but good morning. Okay, does that come up nicely? Yep, beautiful. Thank you, Dorsa. Okay.
Looks good.
Thank you very much. All right, so I am coming to you from Ghana country this morning on the Adelaide Plains. And following on from Trisha's talk there about the evidence gaps, we need to supply you with some data. So that's what NAUSP is. So just a bit of a quick overview of what this presentation will be covering. What is NAUSP, the National Antimicrobial Surveillance Program? What does it look like? What does the data look like? What does it produce? And a bit of a history as to how we got to where we are at the moment. So some challenges with what we do and the data we produce, some opportunities that we've identified, and then hopefully some time at the end for a couple of questions. So if we can't measure, we can't improve. So that's what we're hoping to underpin here, is give you some data to underpin those AMS activities that you're undertaking in your facilities. We want to be able to identify overprescribing or unexpected changes in prescribing through trending data, and obviously participation in NAUSP and NAPS fulfills accreditation with standard 3. So NAUSP is a volume-based method of surveillance. We originally started in Australian hospitals, but now we would probably say healthcare facilities. It has expanded a little bit, and we measure our rates. Now that is in a metric of defined daily doses per 1,000 bed days, or now presentations. And we measure use in adult acute inpatient care. So getting pharmacy dispensing and distribution data, we convert that into the number of grams for each drug, which then gets converted into the number of defined daily doses. That is our numerator for getting a rate. The denominator is hospital activity. So originally that was our overnight bed days, but now looking more importantly at theatre case numbers or ED presentations. And the rate to standardise that is the number of defined daily doses over the activity measure, so overnight bed days or case numbers times 1,000 as the standardisation measure there. So what does the data look like? So a couple of different applications of our data. This particular slide here shows aggregate data presented at national level. So we've got either state or territory or all of Australia's usage rates pulled together as an aggregate presentation. We can do that in a number of fashions. These ones have been pulled from the AURA report. So the top bar chart there is an annual aggregate stratified into classes. The second one there, figure 15, is the longitudinal, so we can see the trend and the changes in usage. At hospital level or benchmarking, first bar chart there, these are our 6 monthly reports where we can benchmark by state or jurisdiction or peer group and identify in a de-identified manner each of those individual sites. So everyone's always quite interested to see how they are performing compared to the place down the road. The little longitudinal charts here are taken from our contributor reports where a hospital can plot their own rates against a chosen benchmark. So those benchmarks can be the state, it could be the national rate, it could be within a specialty, so critical care, it might be within a peer group as well. A bit of overview of the program itself. So 2004 is when we started, motored along quite happily. 2014 is when I came on board, and that's probably when sort of just prior to 2014 or in 2014 where things really started kicking off and exploding, I guess, for us in terms of taking on new contributors regularly. In 2016 is when we had our first major upgrade, building a portal that allowed contributors to submit their data to us themselves. So prior to that, we were manipulating that data and loading that, calculating rates and sending reports back to sites. But in 2016, it was a user-led self-service model. It also let us, for the first time, stratify areas that weren't critical care, that allowed a bit more utility in the data. So looking at those areas that traditionally would have higher rates of antimicrobial prescribing and look at those in a bit more detail. 2017 is when we expanded our data capture, but also tightened up some definitions to ensure that theatre was being captured. So we did discover along the way that there were some sites, if they had a high proportion of day cases, potentially weren't including all of their theatre distributions. Maybe they were, maybe they weren't. But in terms of benchmarking that, it became quite difficult because some of those sites obviously would end up with a higher rate if they had a high proportion of day surgery because there was no associated overnight bed day. At that point, we only had the one denominator to create the rates. So tightening up those definitions, including all of our antimicrobials, including topicals, which leads us to 2021, which is where we are now. So last year we had our biggest portal expansion, and probably the biggest undertaking that we had here within NAUSP was a challenge to get things really working, to give back, I guess, some extra utility and really breaking down these data submissions into cleaner areas that gave better reports and better opportunities for surveillance. So the big pluses: pulling out ED data, pulling out theatre data. These areas don't generally have overnight bed days, and being able to report them against their specific activity measure. So ED usage is now measured against presentations and theatre is against cases. So this levels the playing field. It allows us to put in sites that have only day surgery, so smaller ones particularly. It's not inflating their general total hospital rate because it's been taken out of that pool of acute care usage rates. And it has really double positives here. We've got a much more refined acute data set, and we've got the added bonus of being able to look at theatre by itself. As an aside, we've also put some subacute areas in, which we won't look at today, but that also allowed some other sites to get on board and to really focus on either the subacute or acute data. Now, the rest of, the rest of the presentation, we'll look at just that theatre section there. So you can see we've pulled that out. It's no longer being reported in that acute pool, but as an aside to that. At the moment, we've got 288 sites that are actively registered, so submitting data in a very regular fashion. And it's been so great to see everyone jump on board and actually putting in the effort to stratify all of their data sets. From those, we've got 235 compliant with the new definitions. So we did do a lot of work last year to really engage with our contributors and get everyone on board to make sure that they were able to understand what the changes were and to get that theatre data coming in separately. So a bit of a breakdown by state and peer group there. Now, I haven't shown the Ds, so the Group D hospitals. If they do have theatre data, we will accept it, but we generally don't put it in a benchmark group, only because some of those sites are generally too small and the type of distributions that they have access to for reporting purposes don't really qualify to have that theatre out by itself. We do have a few though. So what do the rates actually look like? And we're a little bit blind coming in last year to kind of anticipate what the actual DDD per 1,000 cases would look like, but it's turned out to be around sort of 3 to 500, 3 to 600 in that range. This doesn't really tell you anything, it's just for interest to see the difference in the sites there. Now, I have put public and private Group A's and B's together. Private sites generally do have a higher load of elective surgery, so some of their theatre rates might be higher just due to the volume of cases that they get. But the principal referral group is what we're going to focus on today. It's the only complete peer group that we have in the NAUSP data sets. Having said that, one site was excluded from this. We haven't got their data at the moment, but mostly because it's the most consistent peer group, meaning that the levels of acuity, characteristics between hospitals in that same group. So these are the tertiary referral hospitals, almost always associated with university and teaching. So looking at those 30 sites, these are the individual rates for 2021 as an aggregate. So all of the DDDs, that are the defined daily doses, over all of the number of cases from January to December for that 1 year. And you can see there's still quite a range of rates coming out. So the aggregate sitting just under 600 The mean also under 600, but still quite a bit of variation in there. Now, keep in mind, this is our most consistent group as well. So looking at the same chart for the group A and the group B, it was just downhill from there in terms of plotting them in this fashion from highest to lowest. So this is our tightest group. So let's have a closer look at what's going on. So these are the offerings as per Google websites under their surgery area. But again, because they're principal referral hospitals, we know that they are high acuity tertiary hospitals. They're pretty on par, but their rates are quite different. So site 1, if we were to benchmark their usage charts, this is what it would look like. So their total IV agents and a few individual ones picked out there. Is this going to be helpful to a contributor? So this is leading us to our first challenge of benchmarking. So all of our other reports have always had a benchmark on them. It gives that indication of where you're tracking against your peer group or selected benchmark group. Same charts then for site 30, which was the lowest use. Same questions. Is this useful? What is this pharmacist going to do with the data when they take it back to their AMS committee? They look, we're going really, really well. We're really tracking very, very well. We're below the benchmark. How does that get interpreted? So another look at the data. So site 1 and site 30, these are the figures, so the raw figures from the data that's been processed through the portal. This is the quantity of things, so the quantity of antimicrobials that have been distributed to the theatre and recovery setting from pharmacy. A bit of difference, but generally consistent and not too crazy. We convert that into the number of grams and it evens out a bit better. Converting that to the number of defined daily doses, so row 3 here, the DDDs, again, pretty close. But converting that to a rate tells us another story. So some of those are very, very different. The difference here is the number of cases, so the denominator that's been supplied to us to create that rate. So the lower rate with site 30 is coming from a much higher number of cases that are being reported to us. So some of them are up to 4 or 5 times higher. Why? So one of the biggest challenges we had that has led to us taking the benchmark off the theatre reports that we do have available via the portal to download is what actually constitutes a theatre case. We're still working on that. The level of transparency that's afforded to AMS pharmacists and ICPs has been really variable. So in chatting to our contributors, it's been quite tricky. So some of the private contributors have had access to much more detailed reporting from their hospital. Sometimes that's because it's attached to dollars, but they're able to break down their monthly cases. So they can give us main theatre, they can give us their cath labs and angios, they can give us their endoscopy suites. Sometimes there's some medical imaging in there. At the end of the scale, so the other end of the scale, other sites just get a single figure reported to them and there's no transparency. They don't know what's going into that. They might even struggle to get that number in the first place or finding the correct person to get that information from. Some LHNs or some states have got a central reporting tool, so all of that data is vacuumed in. There's just that one figure with no real explanation or breakdown or context provided with that. So areas that have high volume caseloads but low drug usage have been the primary driver of the challenge of lack of benchmark. So endoscopy is the big one here. So we can't exclude them from being a theatre case or a presentation, but there's low drug use associated with a high volume of patients coming through those areas. So one area that we're investigating to try and sort of combat this or get around it is creating an extra stratification that comes under theatre. So we would have sites that do include endoscopy in their theatre denominator and sites that don't. So hopefully then we can tease it out a little bit more. But that's not particularly helpful for sites that just have a single figure and they're not sure where that number is coming from. The other challenge that we have, which is going to be unpacked a bit more by Nadine coming up, are things that are distributed to theatre areas that don't go through pharmacy. So the big one is bone cement. So these are the lines or the products that we have existing in the NAUSP database now. There's a few of those, and devices, we've called them. So there's some dressings and beads as well. Now, in the PR group, keeping in mind again that this is our most consistent group, our highest acuity group, a third of them are reporting consistently these products to us. And I can probably tell you most of them come from one state. So where is that data? We're not receiving it. If we can't receive it, we can't measure it. If we can't measure it, we can't improve it. The biggest challenge, I think, with the theatre data is, what is it? And it will be really lovely, following on from Trisha's again, to know that what is in theatre is for theatre, but what exactly is being measured? Where are patients on their journey? So we're not just measuring prophylaxis. And when I first started investigating these theatre data sets, one of the names I came up with was perfect prophylaxis, something similar, but it's not. And it would be really lovely if it was, but it's not. So we do already have patients who have been commenced on antimicrobials before they have a theatre presentation. They receive a dose there. That's not prophylaxis. We get things that are moved around. The drugs that are administered from the theatre impress that aren't actually for theatre patients. We know that things like to go walking, medications grow legs and disappear and get borrowed and never returned. The NAUSP data sets are measuring distributions from pharmacy, so from point A to point B out to theatre. It's more like casting a net over that physical site. So anything that gets distributed to theatre is assumed to have been administered in theatre, which is not always the case. So pre-theatre regimens, what happens if an infusion is commenced prior to the patient actually coming to theatre? That, I'm assuming vancomycin, would be taken from the ward stock or dispensed to that patient directly prior to them physically moving into the theatre setting where we are capturing that data. Same for post-surgical, the cardiac type things. That initial dose would be captured absolutely in theatre, but where are the rest of the doses? So as soon as the patient moves out of that setting, any antimicrobials administered to them are not captured as part of theatre. The other thing I mentioned earlier is movement of stock or other areas that are located adjacent to that area or that impressed. I think too, smaller sites particularly, it would create much more work for pharmacy if every single area had to maintain its own imprest. If there is only one drug cupboard that services multiple areas, all of those things make that interpretation quite tricky. So it really comes down in that regard, as we would always say, you have to interpret the NAUSP reports with your own particular setting in mind, and that's going to be different for every single facility. So just looking at the top 10s. So I have broken the axis on this one because everything below 70 is cefazolin, which is great. But some of the other agents there might be surprising, might not. They are different from peer group to peer group. Again, if someone has come into the theatre setting, already commenced on something and they needed a dose while they were there, that's going to be administered. It's not related to theatre, but it was captured in the theatre data set. Also got some orals in there. Now, so the amoxi, the cefazolin, some trimethoprim, some of that amoxiclav would potentially be oral as well. And the other group at the top. So this graph is the percentage of every agent that has gone to theatre. So the residuals do make an interesting group. We've got some ampicillin, There's quite a few macrolides. There's some benpen, some meroperim, some doxy, some other 3rd and 4th generation cephalosporins, fluoroquinolones are all in there. And the broader spectrum agents, there's also some antifungals as well, which I ran independently quickly, are still being captured in theatre. But not necessarily prophylaxis with those ones. Some unexpected finds or not. So we can't assume that anything that's administered in theatre is parenteral. This was a rate calc that I pulled again from the PR sites, the principal referrals for topical agents. So some of that would not be unexpected at all. We'll draw your attention to the Chlorseq ointment. So a lovely quantity there of 21,000. So that's across the year. Works out to about 13 a week per site, assuming that they're all using that in a similar fashion. But just something to keep in mind for the AMS pharmacists, if there are rate calcs or reports that you're looking into, not to neglect things that you wouldn't necessarily think about straight up. Just on the topicals there. So in terms of some opportunities for us to make this better, going back to the denominator types there, really just asking questions. If you are one of the sites that only has access to a single figure, see what you can do to tease that out. The improved quality of data coming to us can only result in better reporting back to you. We want to provide a service that's useful. So if there's any opportunity to tighten up any of those submissions, obviously we are more than happy to help you do that. It's not unusual for us to reload lots of data in one go. We often have contributors come say, oh, I forgot XYZ impressed, or we've redone our activity and I've got a whole new set of denominators. What can I do? Absolutely, we can reload that data for you. We love to improve that quality and give you better reporting. The stratification of the benchmark groups into those additional areas is something that we're looking into, and obviously electronic data sets will make things interesting. And hopefully that is not going to replace what we're currently doing at the moment, but it might give us an extra layer of information that can help that interpretation. And that's me done. I'll switch there.
Thank you. Thanks very much for that, Erin. I remember back when I first started in ID many, many years ago, NAUSP was really the only national program around that could give us any sort of overlay insight on how a hospital was performing in relation to other hospitals, and this whole concept of benchmarking. And I remember many an AMS committee meeting where we would be talking about our antimicrobial usage, and if there was a blip, then trying to, that was sort of the instigator into us figuring out what that was and whether that was okay or not. So thank you very, very much for that. We have some time for some questions, and there is one in the chat at the moment, which is, when is NAUSP planning on launching the EMA data version?
That might be an Nadine question. I mean, a lot of sites around Australia are only just getting into that space now. Yeah. And we can't offer a service if it only suits, a little wedge. Yeah. And ironing out some of those requirements and those clarifications that are required to get a good product. And obviously paediatric hospitals have been the focus there to offer them something, because paediatrics are excluded from NAUSP, obviously not meeting the WHO DDD requirement. Nadine, do you have anything to add on that?
Yeah, I was just going to say we're working with the IT guys at the moment to try. It's been a long process, so we're doing some testing at the moment. We've got a few sites that have volunteered to be pilots for us, and hopefully in the next sort of, well, I keep saying in the next sort of 3 months, and then something happens. So sometime in the near future would be my answer. Yeah, sorry, it's been unexpectedly challenging.
I think too, look,
yeah,
bringing that back to theatre, the initial anticipation of EMA data or dot reporting had been pinning that back to a specialty. How does that work in the theatre setting? Some extra complexities there,
Yeah.
that we're still ironing out.
Yeah. All right. Thank you very much for that, Erin. So we'll move on to our next speaker, who is Nadine. So Nadine Hillock is a public health pharmacist with an interest in antimicrobial stewardship, hooray, and health economics. She's the program manager for the NAUSP program and is also the senior pharmacist leading the antimicrobial programs team in South Australia Health. She's recently submitted her PhD thesis investigating, well done, investigating alternative funding models for antimicrobials in Australia. And she'll be presenting on antimicrobial-loaded bone cement, filling the gaps. Thank you, Nadine.
Yeah, hold on, I just have to work out how to share my screen, sorry. Sorry, getting there. Can you see that, or that's
No, not yet.
Hold on. It's working before.
That's okay, we've got time.
Yeah, that's okay. I'll try. Can you see that? I'll just put it into presenter mode.
Yeah. So that's in presenter mode at the moment. So if you just switch the display settings up the top. Yeah. Yeah. So where it says display.
Oh, yeah. Sorry. There we go. We good?
Perfect. Lovely.
Sorry about that, Caroline.
No, not at all.
Okay. So today I'm going to take you on a bit of a journey that I've been on over the last 18 months with bone cement discovery. So when I say bone cement discovery, I don't mean that I've personally had a new hip or a knee myself, but it's just my increased knowledge about what's going on with bone cement, because I have to admit that 18 months ago I didn't really know anything at all. I'm also of that age that I've got a number of close friends who've got new hip replacements, and so it isn't surprising really, given the rates of surgery that Trisha mentioned before, and also for arthroplasty surgeries, there's over 100,000 of those surgeries done per annum in Australia. So bone cement, just quickly, the main use of bone cement is to fixate the prosthetic joint. So it's filling the gap really between the prosthesis and the bone. A secondary use for the cement is for antibiotic delivery to the joint to treat or prevent deep surgical infections. Infection is the major complication of joint replacement surgery, and the incidence of infection after a primary joint replacement is roughly 1.7% in Australia. IV prophylaxis is obviously recommended, given this type of surgery involves a prosthetic material. And yeah. So this talk today, I'm going to briefly go over the bone cement that's included in NAUSP data. Erin's given you a little bit of an intro there. And then just I'll talk about a quick survey we did of NAUSP users regarding their knowledge of cement. And I want to briefly discuss the legislation that governs the management and use of antimicrobial-loaded cement in Australia. And then finally, I just want to share some results of a survey of arthroplasty surgeons, which aim to get a better understanding of what is current practice here in Australia. As Erin mentioned before, from the start of January 2021, NAUSP data definitions were expanded to include all antimicrobial products or products that include an antimicrobial that are dispensed or distributed from hospital pharmacies. And we had the upgrade to the portal that she also mentioned, so that it enabled theatre data to be stratified from usage elsewhere in the hospital. Of the 258 hospitals that are currently routinely contributing data right at this moment, 33 of them include antimicrobial-loaded bone cement in their data. Queensland's obviously got the greatest capture, with 17 of their contributing hospitals including bone cement in their data. And of the 31 principal referral hospitals, as Erin said, only 9 of them are actually including bone cement in their NAUSP data. Oh, sorry, I'm not going forward on my slides here. So from January, just go forward. So which products are actually in the NAUSP, well, available in Australia? So these are the products that Erin mentioned before. Gentamicin varies in strength from 500 milligrams and 40 grams of cement up to 1.56 grams and 40 grams of cement. That's the proprietary concentration. There are a couple of combination products that have gentamicin with clindamycin and gentamicin with vancomycin. The main ones stocked by the 33 hospitals reported in the NAUSP data are these 3 here. So a 500 milligram and 40 gram cement, 1 gram and 40 grams, and the tobramycin 1 gram. So to scope pharmacist knowledge, we thought we'd do a survey of NAUSP pharmacists that contribute data to NAUSP. I initially had a chat to the NCAS people, and they kindly gave me an insight into what's captured in the NAPS data. Only 2,406 arthroplasties that were captured in the surgical NAPS, there were only 28 instances of antimicrobial-loaded bone cement reported in the audit. But we do know from the literature that the use of bone cement is commonly used in arthroplasties. And so where is it documented and how is it used? And are pharmacists even aware of where it's documented? So this is where we did the survey to NAUSP portal users, and we asked them these questions. We asked them if their pharmacy was responsible for the management of bone cement, and if not, was it directly to theatre? We asked them which products were stocked in their hospitals, what antimicrobials are added to cement in theatre, if they were aware of any, and where is it documented in the clinical notes. So we had a relatively low response rate. We only had 52 pharmacists respond. Approximately a third said their pharmacy manages the stock of antimicrobial-loaded bone cement in their hospitals. Other options were theatre, which was what we were expecting, general stores, and then other unspecified departments, or a combination. We had some hospitals that would do some of the products via theatre, some via general stores, and some via pharmacy. There was sort of a mixture. As expected, the main products were the gentamicin or the tobramycin single product cements. And when asked if they were aware of antimicrobials that surgeons were adding to cement in theatre, these were the drugs that they were able to come up with. They knew that surgeons were adding additional tobramycin. We had some that knew of amikacin. They knew vancomycin was regularly added. Cipro, ertapenem, meropenem, colistin, which was surprising, daptomycin and voriconazole were some of the drugs that they reported that they knew had been added in theatre. We didn't ask them about the number of times they knew that had happened, just the name of the drug. So when we asked what they knew about the documentation and the patient record, more than half said that the documentation was unclear, or they wouldn't be able to locate it. And they knew, some of them didn't even think that it was documented at all. So I like this quote that I know nothing about bone cement and I wouldn't know where to look or who to talk to. And I think that was me at the start of the year, because I literally would not have known where to go either. So I was aware also that proprietary bone cement products were exempt from the poison standard in Australia, but it wasn't really clear to me from the legislation what the rules were if other Schedule 4 drugs, in this case antimicrobials, are added to the products. Does that product then become exempt from the poison schedule itself, like the added antimicrobial, or does the product itself then become not exempt? It wasn't clear to me at all. So I asked the TGA, and the TGA got back to me and they said that it does not, so any antimicrobial that is added to bone cement is not included in the poison standard. So Schedule 4 antimicrobials, once they're added, they don't need to, they're not considered Schedule 4 anymore, basically. The exemption is irrespective of the number of antimicrobials they contain, or whether the antimicrobials are additional rather than original, like whether they were in the product to begin with or if they've been added to the product. So it's very surprising to me. But moving on. So with no or poor documentation of usage in these products, we're left in this cycle of uncertainty. If it's not documented, we can't evaluate outcomes such as the rate of joint infections relative to the type or dose of antimicrobial added to the cement. And without documentation, we can't include it in the NAUSP audits. And without understanding the benefits and adverse events, we can't develop evidence-based guidelines on the use of antimicrobial-loaded bone cement. And there'll continue to be variation in clinical practice with no real standard of care. So it's this cycle of uncertainty that results from the lack of documentation. So we decided to try and find out what is actually happening. So at the start of this year, the NAUSP team collaborated with 2 orthopaedic surgeons who were also interested in what their colleagues were doing with regard to cement. And we developed an online survey and distributed it to members of the Australian Arthroplasty Society. And we were seeking information on what they did for routine primary procedures, non-infected revisions, high-risk procedures, so for trauma and tumours, and infected revisions. And we had 53 surgeons consented to participate, which is not a lot of surgeons. I realise this is a big limitation of this, but the variation in responses is also quite eye-opening. So for routine primary procedures, so this is first hips or knees, when cement was used, so cement's not always used, but it's usually used. When cement was used, most surgeons preferred a cement that contained gentamicin. Only 3% said they would use a cement without any antimicrobial at all. And we had 6% that said that they would use a cement with gentamicin and clindamycin. This is for routine primary procedures. For non-infected revisions or high risk, so such as in trauma or reconstruction after a tumour, all of them used a cement, a proprietary product that contained antibiotics originally, so usually an aminoglycoside based one, but 18% said that they would add additional antibiotics into that cement. We provided a list of antimicrobials that we were aware of being used. So that was from literature searching and also from our pharmacist survey. And we asked them to state whether they would use them usually, often, sometimes, rarely, or never. Vancomycin was usually or often or usually added as well. This is additionally to sometimes vancomycin was already in the product, but 42% would add more. And another 18% sometimes or rarely added extra vancomycin. Other antibiotics, so sometimes or rarely included gentamicin, clindamycin, tobramycin, daptomycin, meropenem, cefazoline. And then rarely there were the sort of restricted ones that we were hoping were rarely used: amikacin, cipro, ceftazidime, colistin, again, which was surprising, fosfomycin, linezolid, and moxifloxacin. Now this, bearing in mind, these are high-risk revisions, but not infected revisions. So for infected revisions, there was a wide range of responses. The majority used a proprietary product that contained amine glycoside and vancomycin. So that product comes with 2 grams of vancomycin in it already. And most added an additional 1 or 2 grams of vancomycin. They said that they would occasionally add ciprofloxacin as well. If the primary organism was known to be Staph aureus, and we didn't specify MRSA. Oh, actually, I'd have to go back to the data. We for a Staph aureus infection, they were using up to 5 grams of vancomycin and 40 grams of cement for some of the respondents. And then for the non-MRSA, they did say that they would use. We had one respondent that said that they would use Fluclox. And some used clindamycin. The gram-negative joints, there was a mixture as well. So some of them used amikacin, most used gentamicin or tobramycin, and there were some that used cipro. Powder versus liquids added to cement. This is also interesting because the literature suggests that powder is less likely to compromise the joint stability when it's added into the cement. But then there's some other literature that says that liquids may elute higher concentrations of actual drug into the joint space. So potentially there's pros and cons for both. Most use powder, except for gentamicin and tobramycin, which are not included on this graph because they're only available in liquid formulation in Australia, and they are added as liquids. For fungal infections, there's a wide variation in the use of antifungals in cement. Amphotericin was the most popular drug, well, the most commonly reported drug that they had used in the past. And then we've got some of the azoles there, and some of the, we had angulofungin and caspofungin also mentioned. Documentation, when we ask them where they document their, when they add bone cement, most said the prosthetic record. They didn't specify whether they were documenting the additional antimicrobials or not on this. We were just asking them in general, where would they document? It was very varied though. So some did put it in the EMR, some did the EMR and the prosthetic record, some only did it on the operation report, and one just, one said just on the drug chart, which surprised me because they would have to put the actual product, the batch of the cement in the notes somewhere. So I'm not sure where they put that on the drug chart. Interesting. Clinical considerations. So there's a number of clinical considerations that need to be considered with antimicrobial-loaded bone cement. And just to keep to time, because I'm running over time, I won't go into it too much, but here are some of the factors for consideration. The additional antimicrobials affecting the mechanical strength and the stability of the joint. The elution of the antibiotic from the cement into the joint itself is dependent on a number of factors, including the amount of cement that's actually used, the hydrophilicity of the drug itself, the concentration of the drug in the cement, and potentially how many other drugs are also added to the cement. And all of this, of course, affects the efficacy and safety. Some of you may be aware, and others maybe not, that mixing up of bone cement is actually an exothermic reaction. And it gets up to temperatures of 90 to 100 degrees, roughly about 10 minutes in. And this obviously can have an effect on the antimicrobial, the impact of heat on antimicrobial stability. So there's quite a lot of literature on the stability of gentamicin and tobramycin, so the aminoglycosides, which are the main ones used, and they are all heat stable, as is vancomycin. Cefazolin, ceftazidime, and daptomycin are not heat stable. And meropenem, there's conflicting results in the literature. It's obviously not thermodynamically stable. It's thermodynamically unstable in solution, as pharmacists know. When it's made up, it's only stable for up to 3 hours for some of the formulations. But in solid form, there's some evidence that only, 17% degradation during cement polymerization at up to 117 degrees. And then there's a recent study by Levac that was published last year that suggested that it retains its antimicrobial activity for 48 hours. So where does this put us back in our cycle of uncertainty, and how could documentation help us address the gaps in the evidence? Well, it would help us enable outcomes research to determine optimal dosing. It would help us determine which procedures there's a benefit, and if we could somehow get information on the formulations that have been used as well, like powders versus liquids, we could then correlate that with outcomes as well. There is a risk of systemic effects with adding these drugs to cement. These drugs are mostly nephrotoxic, and the patients receiving them are mostly older and with reduced renal function. And there is documented cases in the literature of acute kidney injury as a complication of arthroplasty, but it's likely to be underestimated. So in summary, what can we do to address the evidence gaps? And as antimicrobial stewards, how can we improve practice? Well, to develop guidelines, first we need the evidence. We can advocate for better, consistent documentation, and we can also advocate nationally to at a legislative level. It's difficult to enforce something, particularly documentation, unless there's legislation or policy mandating it. There's room for further education of pharmacists to increase their knowledge about the practice itself, and also for surgeons and theatre staff, so that they're aware of the importance of documentation. But while AMS can be in the surgical setting can be challenging, and I'm sure Courtney's going to share her experience and expertise in this area, there does need to be an increased awareness of surgeons about the importance of documentation, and then we'll be able to actually conduct, proper audits in the setting, and also look at the correlation with surgical site infections. And obviously there's space for research into understanding the doses and the elution kinetics and the impact on adverse effects as well. And that is all.
Thank you, Nadine. That was really, really fascinating presentation on a complex topic that I think really sort of challenges our traditional notions of how antimicrobials and drugs are administered. We do have some time for some questions, but I was wondering, out of interest, do patients get detectable drug levels? Do you know? After it's the gent and the bank has been installed, so to speak?
Yeah, no. So I've actually looked at the literature, because I think that's a potential student project.
Mm-hmm.
I definitely think there should be some TDM sort of research done. There was one study from a long time ago. There's not a lot of good literature on this at all. So yes, it's absolutely an area where research into that should be happening. But I think the problem we've got at the moment is that we actually, because so much is not documented, we actually don't know what is going on.
Yeah.
And to get that improved first, I think is probably the first step. But yeah, you're right, it's an area that I'm really interested in as well.
yeah, it would be fascinating, or particularly if the patients then need systemic gentle makeover on top of that and how you manage
Yes.
that.
Yeah.
Also, I couldn't quite remember, but when you were showing your list of the various different antimicrobials that your survey respondents, were there beta-lactams as part of that, or was it?
No. So
Oh,
no. They're tending to target the things that are most commonly, the cause of infection. So they are tending to. They know that fluclox is not stable in the bone cement. Some of them do. They're tending towards the use of vancomycin and and covering the gram negatives as well, I think. And because it didn't come back in the pharmacist survey, and it's not really in the literature, there's really no use of
I suppose I was interested because I know traditionally when they're given IV, there's concerns around sort of stability if you're mixing. Like I remember Gent is not compatible with beta-lactams, and vancomycin is not compatible with beta-lactams as well. So I was interested that if they were putting those combinations together, if there were actual incompatibility issues too, but who knows?
It's a huge area where there's so much uncertainty. So I think highlighting it, hopefully pharmacists will take it up as potential, topics to further.
Oh, absolutely. It's just ripe for some research. We do have a question that's come through on the Q&A. Do the bone cement manufacturers have any extra data regarding the percentages and the strengths, etc.?
I haven't contacted them directly myself. This is an off-label use of the product, and so they probably won't, even if they've got the data, they may not disclose it. But yeah, I mean, they would obviously have data on their products themselves, the ones that have got their aminoglycosides. But yeah, the off-label side of it, I doubt you'd be able to get the data from them.
Yeah. All right. Are there any other questions for Nadine? Okay, if not, thank you very much, Nadine, and we'll move on to our final presentation by Courtney, who I have the absolute pleasure of working with on a daily basis. So Courtney is an ID and AMS pharmacist and a postdoctoral fellow with NCAS, and she's also the program manager for the NAUSP, the National Antimicrobial Prescribing Survey. Her PhD work and continued research aims to optimise antimicrobial use in the peri-operative setting. Thank you very much,
everyone. So today for my talk, I'll be discussing about how to apply a learning health systems approach to surgical AMS. At first, when Kaz asked me to present on this topic, I had a bit of a moment of panic. It's been a while. I've been in more of a clinical role for the last 2 years and haven't really had much of an opportunity to follow up and pursue on my doctoral program that really focused on this topic. So this is more of a me having a reflection, and I'm also currently participating in a course on the learning health system. So I've come to learn along the way that most health services research and quality improvement projects like AMS programs very much lean into this framework. So as you can see by this very beautiful but intense diagram, you might have seen this as well if you attended our symposium on Friday. But a learning health system, what is it? It's a system in which science, informatics, incentives and culture are aligned for continuous improvement and innovation. So, and not only that, we want to be using best practices that are seamlessly embedded in a delivery process, not just with our clinicians, but with patients and families as active participants, and generating and capturing new knowledge as part of this experience. The focus of an LHS is to collect data to generate knowledge, so this D to K, and apply it to then improve practice by informing deliberate processes and directly feeding decision support systems. It's important to note that this diagram then forms into like a loop in itself. sorry, I'll just minimize the screen, loop in itself. And, it's more of an ongoing journey, which, all of us in this space, whether it's research or stewardship, you don't just do something and then it stops. It's a never ending journey. And that's what I found quite interesting on learning about this learning health system. So the purposes of my talk, I'll be reflecting on this practice to data component, and then how we use that data to generate knowledge, and then finally some thoughts for the implementation of that knowledge derived from my doctoral program to ideally improve practice. So first up, under practice to data, one of the core tasks was to establish a learning community. So I was incredibly fortunate to have won a scholarship to complete my PhD with the NCAS. So I was very lucky. I walked into an already established learning community. So the NCAS, they take a One Health approach to antimicrobial use. It's a group made of infectious diseases specialists, clinical microbiologists, general practitioners, pharmacists, nurses, infection control specialists, veterinarians, epidemiologists, and bioethicists. Within this group, there are many research streams and with many other PhDs that I got to learn from and collaborate with. So first step, tick. Specifically within this learning community, I had a stellar lineup of PhD supervisors with expertise in ID, AMS, infection prevention, control, and surgery. And with this additional impact of Darshini, Dr. Aiton, who was an expert qualitative researcher who provided that critical contribution of the overarching methodological design of my program and that qualitative research, which was something that I'd never done before. With the overlapping of the NCAS and the NAUSP team, I was very well supported by experts in the field of people who had developed the NAUSP program. And also a shout out to Arjun, who also provided his expertise to my qualitative research and did his very best to help improve my writing skills. The next step is then to identify the problem. So how do we even know there's a problem with surgical antimicrobial use in Australia? As I set out to understand and identify the problem, I recognise there are a few key questions that I would need to answer. Well, at least try to. So why do we care? What's the status of surgical antimicrobial use? How do we improve it? What's the evidence? Who are the key players? So your prescribers, decision makers, administrators. When are these decisions made? What's the workflow like? Where can we direct interventions to optimise their use? What's the environment? And why are these decisions made? What are the underlying influences? So firstly, why do we care? Trish did a much better job at articulating this, but just to reiterate some key points. We know that surgical site infections cause direct patient harm, and they contribute to prolonged length of stay, which then have costs to both the patient and the healthcare system. When antimicrobials are administered to help prevent these infections, so warrants the use. But when we also know that when antimicrobials are prescribed for prolonged periods or unnecessary exposure, there are risks, and that's such as Clostridioides difficile, toxicities, and side effects. Further to that, there's community level risks like antimicrobial resistance, and then linking that back in together, we know that surgical antimicrobial prophylaxis, or SAP, that I'll refer to it throughout this talk, is one of the most strongly evidence-based measures for surgical site infection prevention. So antibiotics are important in this space to minimise harm, but we also need to balance that with unnecessary exposure. So then to answer all the remaining questions, we thought the best way to approach this was with a mixed methods approach, utilising both quantitative and qualitative research methods, with an overarching aim to explore challenges in SAP prescribing and the strategies for the optimisation of SAP prescribing in Australia. So moving on to the next stage of generating and analysing data to generate more knowledge. We wanted to understand what the status of SAP use was in Australia. For us to do that, we need to identify any existing data sources. So for me, I was very, very fortunate. We have the NAUSP, the National Antimicrobial Prescribing Survey, that's consistently identified over the last few years that surgical antimicrobial prophylaxis was the most common indication for antibiotic use in Australian hospitals. Not only was it the most common indication, but it was consistently identified to have high rates of inappropriate use. Given the implications of the point prevalence survey methodology of the hospital NAPS, the NAPS team looked to further examine surgical prescribing in a more detailed way. And from that, the surgical NAPS was born. And to quickly illustrate some key findings, I've got some unpublished results from the latest 2021 data. And that highlights that we've got an increasing uptake in facilities, over 180, and they continue to reveal really poor rates of appropriateness. And the division is even further when you compare procedural doses at 69% appropriate to 37% appropriateness for your post-procedural doses. So then, to describe the current SAP prescribing practices, we accessed this surgical NAPS data set, and this then underwent data transformation, cleaning, and multiple analyses. And this led to 3 key publications from my PhD. So this first one looked at appropriateness and adopted a novel statistical measure of adjusted appropriateness. This measure factored in a range of clinical, hospital, and surgical variables. Once the model factored these in, we calculated this adjusted appropriateness, which was found to be low for pretty much all surgical procedure groups. And whilst this range was broad, from 20 to 70%, this key body of work highlighted that, there's still significant improvement that was required across the board, and not one surgical specialty was to blame for the poor state of prescribing. Then our second paper here looked at antimicrobial choice, which Trish touched on in her talk too. So we understood that cefazolin was the most commonly prescribed antimicrobial, and with good reason, as it's what's recommended nationally. This project looked at antimicrobials and demonstrated that certain procedure groups were likely to use alternative or additional antimicrobials that were not necessarily guideline compliant. And one example of that was that Trish mentioned the use of vancomycin, and then the other is the use of 3rd and 4th generation cephalosporins in abdominal and urological procedures. And then the third project recognised that orthopaedic surgery was the most commonly audited procedure group in the national reports each year. This data set collected data at the type of surgical procedure that we don't normally include in the national reports. So this was more of a deep dive into all the types of orthopaedic procedures to identify more specific targets as to where we can optimise antimicrobial use. An example of this was diagnostic knee arthroscopy procedures don't require surgical prophylaxis, and therefore they were associated with the lowest rates of appropriateness for procedural dose, 36%, and post-procedural dose, 30%. So then through these 3 projects that were generated, we developed an understanding of what's happening with antimicrobial use in this setting and where best we can direct our efforts to optimise use. In terms of how to optimise surgical antimicrobial use, we refer to the literature. And the most recent Cochrane review identified a range of effective types of interventions that included audit and feedback, educational meetings and physical reminders, and then just highlighting that the surgical NAPS forms part of that audit and feedback process. So mixing that knowledge that we generated from the literature review, the national reports and the quantitative research that was being undertaken, we recognised that there was a need to generate new data to achieve this objective 3, identifying, exploring underlying facilitators and barriers. This sought to understand who is involved in the space if we wish to optimise use. When are the decisions being made? Where can we direct our efforts? Why are the decisions being made? What are these underlying influences? So we conducted an exploratory multi-site collective qualitative case study through the use of focus groups and semi-structured interviews. In terms of recruitment, we adopted purposive sampling with additional snowball and iterative sampling to get the right types of participants that were representative of public and private hospitals across a range of disciplines, including surgeons, anaesthetists, nurses, and pharmacists. And more specifically, we sought representation from a range of surgical specialties and differing levels of their career, from residents, registrars, and consultants. All these focus groups were recorded and transcribed, and the transcriptions were underwent secondary review for any errors. To improve their validity, about 20% were double coded, and all coding was deductive in relation to the theoretical domains framework and the COM-B model, so capabilities, opportunities, and motivators for behaviour model. We chose to use this framework for numerous reasons, to help increase understanding of behaviour and behaviour change, because that's what we seek to do when we want to improve prescribing, because it's a behaviour. It provided a structure to the analyses, helped identify enablers and barriers, which was, the objective of the project, assist in the implementation, development, and evaluation of the project. And there's evidence to suggest by adopting this framework, where the TDF and COM-B form into this behaviour change wheel, helps increase the proposed interventions to be appropriate, because you've factored in all these constructs. And there's evidence to suggest that this behaviour change wheel is effective in developing targeted health behaviour change interventions. So using the literature to help provide a theoretical basis to the work. So from this work, this led to one of my key publications that Trisha also spoke about. And from that data analysis, we had multiple key findings. So that multiple factors influence SAP prescribing, and education isn't solely effective. We know that surgeons are generally aware of evidence and guidelines, but more to this, we need to address other issues such as inter and intradisciplinary hierarchy, the importance of providing greater clarity to the roles and responsibilities of SAP, whether it's prescribing and administration and documentation. And touching on Nadine's comments about documentation, we need to provide our clinicians with better resources and understanding of what needs to be documented, and then also the need to develop resources to support and the collection and dissemination of data for action. When I say data for action, I'm talking about the surgeons spoke about the need for they want to know not just about appropriateness of prescribing, they want to know about the outcomes, and that they need to be able to link that data for them to generate, for them to want to change their behaviour, and whether they prescribe for shorter durations. And then also recognising that each surgical specialty have their own unique risks from surgery, infection risks and concerns. So you can't just propose one intervention and assume that it's going to work for every surgical craft group. So with all of this knowledge that we've generated throughout the program, what can we do with it? We need to re-identify and clarify the problem. From what we learned, is this still the same? To do this, we need to triangulate this quantitative and qualitative data together. So the quantitative data helped us identify many areas for improvement. So procedural dose timing, post-procedural duration, the broad spectrum antibiotic use across targeted procedures. So like I mentioned, the 3rd and 4th generation cephalosporins in urological and abdominal procedures. When we target the surgical procedure groups, do we want to target procedure groups that are performed and audited in high volume, like orthopedics, or ones where we know that inappropriateness is quite high, like plastic and reconstructive surgery, breast surgery, dental alveolar and head and neck surgery? Or do we look where surgical prophylaxis is not indicated but still administered, like those arthroscopy procedures I mentioned, or other clean procedures where there's no insertional or removal of prosthetic material? We then triangulate that with our qualitative data, which provides the context and the why behind the results. And this then helps us identify areas for ongoing research. So we recognise that, there's no standardised or national approach to facilitate benchmarking and quality improvement of surgical infections. We still need to measure prophylaxis quality, that appropriateness, because that's still really meaningful. But we need a way to link these two measures together. And that whole process of data collection is quite time consuming for whoever's doing it, which in my role as the NAUSP program manager, it's a lot of our pharmacists on the ground collecting this data and our nursing staff. Can this be automated? And, what's the role for machine learning and natural language processing here? We further need to understand other contextual influences regarding decision making. So at the time of the qualitative research that we didn't really hone in on the impact of digital health and EMR systems. So that's something that I think going forward definitely needs to be done. And, putting this all together, should we have this more national standardized framework for surgical stewardship? So at the time of writing up my thesis, my proposed solution was a theoretically informed framework for surgical AMS. So this is just a screenshot of the overarching themes and stages. And in hindsight, I'd like to think I'm not too far off from the learning health systems framework. I recognise that, collaboration and engagement were important at the start, similar to establishing the learning community. And then that need for meaningful data for action that's going to drive practice and behaviour change. And then finally, a quality improvement program or intervention. The idea at the time was that this intervention would be multifaceted and incorporated digital health solutions in the form of computerised decision support that's complemented by other well-established AMS interventions like education, audit and feedback. So what now? This framework, I submitted my thesis in 2020, so it needs a bit of a shake-up. It needs further refinement, development, then just to scope out the implementation and evaluation, because ultimately we want to support a scalable national program. So in the interest of time, I thought I would discuss what the next steps would be if we continued on this learning health systems journey with a bit less of a shake-up. So continuing on this knowledge to practice venture, I've made up a list of actions to be taken, and these are based upon what I've learned through the learning health system course. So we need to ideate and keep brainstorming potential digital health solutions. We need to be empathising and engaging with our end users, so our surgeons, anaesthetists, nurses, pharmacists, and our technology counterparts in the EMR teams. Need to recognise that we have some new key stakeholders that we need to engage with, specifically the Centre for Digital Transformation of Health, our co-design experts, implementation scientists, and user interface, user experience design experts, particularly if we want to have a digital health solution that's interoperable into our EMR systems. So I need to sort of re-establish this learning community, not necessarily, change it, but it's more change who's already there, but to add to it and build upon this learning community as we progress forward. So then once you, all theoretical, once we've agreed on an appropriate intervention, we would then need to undertake an environmental scan, which is identifying and monitoring factors from both inside and outside an organisation that may impact the long-term viability of the intervention itself. So externally, we look at what's new in the literature. Internally, this image here from David Owens kind of provides a nice sort of summary of all the constraints, but you need to look at the organisation's readiness and capacity to take on the intervention and change, your stakeholder mapping, clinical workflow, understanding that and where the intervention would fit, and especially for your digital health solutions, that information system mapping. We then need to do a gap analysis of the internal and external scans and those findings, and then evaluate and impact the feasibility of the intervention. And there's a whole range of methodologies to consider here, and that would be dependent on the type of intervention proposed. So moving along, once the digital health intervention's been designed and mapped accordingly, the next step would be to develop and test the intervention, and ideally would be validated in a simulated setting. So at the University of Melbourne, the Centre of Digital Transformation of Health have recently released their Digital Health Validitron. It includes a Validitron sandbox, which we can use to rapidly prototype the solution or intervention in a way that considers the existing clinical information systems, the emerging standards, and the innovative technologies in the one space. And then to prototype to see if that then fits into the clinical workflow, there's a Validitron Sim Lab, and that provides like an immersive physical space designed to test and improve the usability, acceptability, and safety. So by piloting and developing the product in this simulated environment is, going to ideally make this intervention more likely to succeed in a pilot setting. And then after, fingers crossed, hopefully a successful pilot, they then move on to an implementation phase, which loops us back into the practice to data phase here, focusing on the importance of designing that robust trial with outcomes that can be measured, ensuring sustainability, interoperability, and scalability, and introduces concepts of implementation and evaluation. And this is just, that ongoing endless loop that we would be continuing for refinement of a program. So some key take-home messages. AMS is always the tip of an iceberg. When we start looking into a problem, we reveal that there's all these other things going on underneath the surface, especially in surgery, as Nadine alluded to, with all the work that's all the things happening in the bone cement space that we're not even aware of because we don't have the proper documentation. As Trish said, surgery is common, and therefore an antimicrobial use in surgery is also very common, and therefore a key target for stewardship. A multifactorial and disciplinary approach is essential. Health services research utilising mixed methods is important and beneficial in this space. And a learning health systems framework provides a good structure to support effective and sustainable quality improvement. And there is a lot to learn about the development and implementation of digital health solutions in general, but also in the stewardship space. They're my references. I want to thank many, many people, such as my employers, and also the Centre for Digital Transformation of Health, because I'm doing this course on learning health system and learning a lot from it. I've also got the link, which I'll post into the chat for those that are interested. And a shameless plug for Antibiotic Awareness Week. After us today, we've got the Fleming Funds fellows talking about international AMS opportunities, AMS in specific settings across pediatrics and dentistry. And then tonight, AMS or antibiotic prescribing in general practice. And then tomorrow, the immunocompromised patient and aged care as topics. So thanks everyone for listening in, and I'll hand back over to Caroline.
Thank you very much, Courtney. That was a really, really great summary of how we can use a lot of the learning health system principles for actually a lot of what we do, in particular surgical prophylaxis. If anyone's got any questions, please type them into the Q&A, or you can electronically raise your hand and we can give you the ability to talk, or if any of our other team members have any questions or comments. Courtney, I just on the topic of the NAUSP, which is close to our heart, I wonder if, so the whole NAUSP platform is undergoing a bit of a redesign and review, and I suppose I wondered if you could give a brief summary of the surgical module in particular, and whether there are any things that you we would be recommending to improve or to change with the new version?
Thanks, Kaz.
No, just going to say for all the participants online, can you press like the reaction button if you've actually done one of the SNAPS audits, just out of interest?
Yeah, while I we'll let that happen while I answer Caroline's question. I'll say Caroline because there's too many Kaz's.
Yeah.
I've spent a lot of time being involved in cleaning the surgical NAUSP data for the national reports, and some of the things that we've spoken about is even if we can't automate the full process, but just, some interim steps of making cefazolin default to IV and cefalexin to oral. Just little simple things that will also save our auditors time when entering data. Interested to liaise with our NAUSP colleagues about how can we provide a more cleaner way for people to document bone cement in the surgical NAUSP, as we've had a chat and it's not done quite well at the moment. And that also comes down to it might not just be documented in the first place, but if we can provide our auditors with a better way to do that as well, help close that loop within the surgical NAUSP that we've spoken about is, ideally helping our auditors, giving more examples of the intricacies of appropriateness and reviewing and refining that matrix, because, there's just so many intricacies there that, we do our best to cover, but it does need a bit of a revision, especially as guidelines are being updated over time.
Yeah.
And I think in terms of changing practice, it really does need to be a multi-pronged approach, and it's not easy. I think that in the qualitative work that I did with Courtney in her PhD and with Trisha, of course, it is really interesting to hear about the opinions from the anaesthetists and the surgeons from various specialties. And if you want some fantastic bedtime reading, maybe put that link to that publication in the chat. It's just a fantastic insight into the minds of our surgeons, how a neurosurgeon thinks about antimicrobials versus a colorectal surgeon versus a plastic, and what drives their motivation. And what really came out, which is really very interesting, is that one of the things that would drive them to change behaviour is that data, good data, and benchmarking and peer comparison. And it's very hard to make because of prolonged prescribing. I've always found it difficult because they need the evidence to see why they need to see if the patient's going to do equally well as not having them spend time on 5 days of cefalexin. With that, we need to have a much more comprehensive approach, and also to have studies like what Trisha's doing, which is going to have that follow-up, and it's just so essential to be designing these really high quality clinical trials that can provide some of those answers. So it's a really tricky and challenging area to work in. I don't know whether you want to make a comment, Trish.
Yeah, I totally agree that, unless you can show them that it's not going to harm people, they're not going to change. The challenge is to do these trials, you do need big numbers and funding, which obviously for those in research know, we're operating in a pretty tight environment, but then there's some efficiencies. So that's where things like platform trials and so on may actually be able to really give us the answers quickly and embed them and try to move things along and really answer some of these questions.
And then the other thing is the opportunity to band you together. So get multiple organisations at different levels to say, right, let's do 30 plastics cases, or let's do 30 colorectal cases, and then you can aggregate the data and have a really good look. At the moment we have not quite significant contributions from both public and private there's so much interesting data, and anyone who is looking to do even if it's a small project, you're very welcome to contact NCAS, and we can help you do a study using the SNAPS data. So we regularly have medical students and our PhD fellows doing analyses of various aspects, and that's absolutely open to any of you online.
Thanks very much. And that brings us to the end of our session this morning. I'd like to thank all of our presenters, Trish, Erin, Nadine and Courtney, on a really, really fantastic session. The whole session has been recorded, and pending no other further technical difficulties, our intention is to make it available on the NCAS website by the end of the year. So without much further ado, thank you very much to everyone participating, and have a good day. Bye.